Hey, Dr. Escalon, can you hear me?
Yes, I can hear you.
Okay, cool. So, welcome to speak with us. So, my name is Islam. I'm a radiology resident at Bana University, and we have the Egyptian Society of Radiology and the Department of Radiology, Bana University. You are welcome to speak to us today. So, Dr. Joanna Escalon, she is an assistant professor of radiology at Weill Cornell Medicine, and she is assistant attending radiologist at New York Hospital Weill campus. She will speak today about cystic lung disease, and you can start right now, okay?
I see a lot of names, not too many faces, but I know there's very nice faces behind all the little gray squares. So hello, everyone, and it's an honor to speak to you today, and thank you so much for inviting me. I'll go ahead and share my screen. So can everybody see the PowerPoint in full screen?
Yes.
Okay, great. As Islam said, I'll be speaking today about cystic lung disease. I have no conflicts of interest. A little bit about myself, just so you know who's speaking to you. I grew up in New Jersey, in the United States. I did my undergraduate at the University of Chicago, medical school at NYU in New York, followed by radiology residency at Cornell. Did a fellowship in cardiothoracic imaging in Colorado at National Jewish Health and the University of Colorado. And then I came back to New York and started as attending back in 2018 at Cornell. So today I'll be talking to you about cystic lung disease. I've divided this talk into two main parts with a little finale. First, we'll be talking about processes that cause cysts, but they don't really consider diffuse cystic lung diseases. And then we'll dive into cystic lung diseases with a more in-depth case-based look at the major cystic lung diseases that I feel are can be hard to distinguish. And I'll highlight a couple helpful, unique features that might help you distinguish them. And at the end, I'll provide an approach to help you narrow the diagnosis. And you might see a little play on the Dr. Seuss book, One Fish, Two Fish, Red Fish, Blue Fish, as we go along. So starting with the entities that can cause cysts but aren't really cystic lung diseases. So for each case I show, I'll give you kind of a moment to take a look at it. Here we see a small cyst in the right apex with an associated pneumothorax. This is just a bleb with a right pneumothorax. What is a bleb? It's just a small gas-containing space within the visceral pleura. And by definition, it's less than 1 centimeter in size. That's in contrast to these larger cystic spaces, clearly greater than 1 centimeter. These are within the lung. These are areas of bullae. They are well-defined areas of emphysema, usually by definition greater than 1 centimeter in size, thin-walled, and usually you see other areas of emphysema associated with them. So you might be wondering, what about a bleb versus a bulla versus paraseptal emphysema? Can we always tell the difference? They're all gas-containing spaces. Part of it is just definitions. The bleb is actually within the visceral pleura, not within the lung parenchyma itself, but that's something that's hard for us to discern on CT. It's by definition, like we said, less than 1 centimeter, whereas a bulla is in the lung and greater than 1 centimeter. Paraseptal emphysema is emphysema that involves the distal acinus, as opposed to central lobular emphysema, which involves the proximal acinus, and panlobular emphysema that involves the whole acinus. Paraseptal emphysema and blebs really, I think, can be very difficult or impossible to distinguish. Usually we're making that decision based on the presence of other forms of emphysema within the same patient to lean towards paraseptal emphysema. In this next case, these are actually two different patients. You see a cyst, but both of them have air fluid levels and a little bit of surrounding ground glass. Now, what would be helpful in these cases, if you knew a little history, they both were in different cases of trauma. So these are post-traumatic pneumatoceles, and the ground glass is a bit of surrounding hemorrhage. So what they represent are pulmonary lacerations. So for example, if someone sustains a stab wound, you might be wondering, a knife is straight. Why isn't this just a straight line in the lungs of gas? Well, the elastic recoil of the lung actually pulls that laceration open, causing retraction of the parenchyma, and the defect to appear round or oval. It then fills with either air or blood, like you see in those two cases. These usually appear within 1 to 3 days of the laceration. But interestingly, the contusion around the laceration heals before the laceration itself heals. So you can imagine, digging into the chart and finding a history of trauma like this is very important, because if you don't have that ground glass around it, it might be harder for you to interpret just that little cystic space with air fluid level. So other than post-infectious nematoceles, post-traumatic nematoceles, you also can get, like in the setting of trauma from stab wound, you can also get it in the setting of barotrauma, like in COVID. So COVID can, in and of itself, the infection can cause nematoceles, but oftentimes it's due to barotrauma from extended mechanical ventilation. And we've actually been seeing a lot of this, not surprisingly, because of the rates of COVID, but also because it actually has been found that barotrauma with ARDS COVID is actually higher. There are higher rates of barotrauma in ARDS COVID than from ARDS due to non-COVID related diseases. Here's another cystic lesion. This one a bit different, right? Multiloculated, multicystic lesion. I'll give you a clue. Try to think of kids when you're looking at this lesion, even though it's in an adult. It's very focal. This is actually congenital pulmonary airway malformation. So that's a congenital hamartomatous lesion of the lung with cyst production. It communicates with the tracheobronchial tree, and what we see on imaging is pretty variable size and thickness of cysts, and usually focal in one spot. Now, this is also a congenital lesion of sorts, but we usually see it when the kid is all grown up. And I have the arrow sign as a clue. Here's another image. There's a large vessel arising from the aorta, leading to this cystic lesion in the left lower lobe. This is interlobar sequestration, the cystic type. So just to remind you all, extralobar sequestration is typically confined by its own pleura and typically found in the neonatal period with systemic arterial and systemic venous drainage. Whereas intralobar, which is most of what we see, I'm an adult imager though, and it is 75% of cases, has a share pleura usually found in children and adults when they become symptomatic from pneumonia or abscesses. And they have systemic arterial supply, but pulmonary venous drainage. And the key in the diagnosis is, in these cases, is really to identify that systemic arterial supply, which was really large in this case, but can sometimes be more subtle. So here we have a ground glass nodule with some cystic spaces centrally. Again, a ground glass nodule with some central lucency or cystic change. This is actually an adenocarcinoma. So adenocarcinomas, as they go from atypical adenomatous hyperplasia all the way to an invasive adenocarcinoma, can develop what we call pseudocavitation. It's not really cavitation per se. Oftentimes it represents dilated airways being pulled open by the desmoplastic reaction that the cancer creates. But you can see that you have a clue to that diagnosis because there's a bit of surrounding ground glass in both of these cases, and there's that mural nodularity that we often see, the mural thickening. Now, why is this important? Oh, I'll show you one other case. So this is actually a kind of scary case where we saw a cyst in the lung, and none of us would have followed this in any way, but 33 months later, the patient came back, perhaps symptomatic with a cough, and we saw new mural thickening along this cystic space. Now, there's no air fluid level to suggest that it's infected. It actually ended up being an adenocarcinoma that arose within a pre-existing pulmonary cystic space. So you can have lung cancers that develop cystic change and those that develop within a cystic airspace as well. So if you do see nodularity developing in a cyst, think of these kinds of entities. So why is this important? Well, lung cancer is associated with cysts, occur in about 3.7% of cases. And even more importantly, in the Nelson trial, 22.7% of missed cancers were those associated with cysts. It took us a while to recognize that this was an entity and understand that adenocarcinomas in particular can have cystic change, and to understand that appearance. So much so that we finally, just this month, got LungRADS 2022 released, and it even includes advice on how to follow up these atypical pulmonary cysts with mural nodularity. Going into this is kind of beyond the scope of this talk, but it just got released this month. Very exciting. So moving on to other causes of cysts. In this section, I'll be talking about diseases that can have secondary cystic change, but it's not the primary process going on. First, we'll start with interstitial lung disease. So here we have a smoker, and you can see that they have upper lobe predominant emphysema and lower lung predominant ground glass opacities and a couple cysts. Give you a moment to think about it. This is a case of desquamative interstitial pneumonia, or DIP. And you can see a companion case here, again, with the diffuse lower lung predominant ground glass opacities and a couple cysts. And usually in these cases, you're going to see coexistent emphysema. These cases pretty much all occur in smokers with an average pack year of 18 pack years. It's on the continuum of respiratory bronchiolitis ILD, and DIP. Now, when I draw this with the little arrows, that's not to say that a patient starts with RB and then gets RB-ILD and then gets DIP. We've never seen that progression. You can think about it even logically. RB is typically an upper lobe predominant disease, where DIP is clearly lower lung predominant. Now, why is it on a continuum? Well, it's really a pathologic continuum. So it's involving more of the lung as you go from RB to DIP. So RB is really the inflammation, and macrophages are surrounding the airways, whereas DIP, it's more diffuse throughout the lung and into the alveolar space. This mainly involves men greater than females. The treatment is smoking cessation and steroids, and 25% progress despite therapy. Here's just another companion case with lower lung predominant ground glass opacities and some cysts. I see some stuff in the chat. I'm not sure if I see. Okay. Oh, excellent. I'm seeing people answering the questions. Awesome. All right, moving on. So here is another case. Truly, honestly, by imaging, I think it is a difficult or impossible diagnosis to make, but I'm going to give you some clues from the history. So this is a 27-year-old. They are from Puerto Rico, and they are albino. So that should make you think of one entity. And just to point out what we're seeing some ground glass, septal thickening, reticulation, some subpleural cysts. Again, it's a non-specific imaging, but this is Hermansky-Putlick syndrome. Just based on the history alone, you can suggest this diagnosis. So this is a rare genetic syndrome involving albinism, platelet dysfunction, and abnormal storage of autofluorescent pigment. In North America, at least, most patients are from Puerto Rico. On imaging, it tends to have a fairly even distribution, like you saw in this case, sometimes a mid to lower lung predominance. Essentially, they get a slowly progressive fibrosis that might have some cysts involved as well. So moving on to infection, which can also cause cysts. So here we have a case with ground glass on the initial imaging, and then they develop these cysts later on. I'll give you all a clue. They have HIV and a CD4 count less than 200. Again, we have bilateral central predominant ground glass opacities that then later develops cysts, in this case, infectious nematoceles with varying shape, size, and wall thickness. This is pneumocystis pneumonia. So here I show you a companion case where they mainly have that central predominant ground glass, which is what you're usually going to see. The peripheral sparing is pretty typical. You might think of other things like diffuse alveolar hemorrhage can also spare the periphery. So that could be near differential pulmonary edema. But in pulmonary edema, while the periphery can be spared, there's usually effusions, whereas effusions are rare in pneumocystis pneumonia. Pneumocystis pneumonia might also have a crazy paving pattern. Cysts occur in about approximately 1/3 of these patients. The cysts might resolve after treatment or become fixed, and they vary in shape, size, and wall thickness, and they're usually upper lung predominant, similar to the ground glass opacities. So in this next infection, this patient had a cough and recurrent respiratory infections. So there will be 2 sets of images on this patient. Here's the second set. Focusing your attention on the airways. All right, so we have nodular lesions of the trachea and cavitary nodules in the posterior lungs. What is this? This is tracheobronchial papillomatosis. So here on the left, you can see I show a companion case where you see, again, the posterior predominance of the nodules, and then they develop cavities moving forward. So this is an HPV, upper respiratory tract infection. It has a bimodal age distribution, so it's more common in children who get the infection via the placenta or childbirth, but it can occur in adults. What you're going to see on imaging is nodular thickened airways, solid or cavitary nodules, usually with a thin or moderately thick walled, like you see in these cases. And they tend to seed the posterior lungs because it's coming from the airways, and and as you lay down, it's kind of that dependent distribution. Most nodules just grow slowly, but do keep in mind that although rare, rapid growth of a nodule does suggest squamous cell carcinoma, which can happen, which these patients are at risk for due to the HPV infection. Right, really interesting case here. I spent some time as a resident in Ethiopia, and that's where I saw this case. I'll give you a clue. This, at least as a kind of a fake history, I don't know the patient's actual clinical history, but let's say that they were a sheep herder.
Can you see the chat box? I think everyone's answering there.
Oh yes, I can see. You guys are doing great. I'm taking a look. Keep it up. I like the responses. Thank you.
Okay.
Yeah, I saw somebody said the water lily sign. Awesome. Okay. Yeah, we see a single large cyst in the lung. And yes, this is the water lily sign. So these are floating membranes within the pericyst. So this is a echinococcal disease, as many of you said. And those of you that didn't get it, perhaps you would have gotten it if it was in the liver. Because that's the most common place that we see it. But lungs are actually a close second, or maybe not a close second, but at least second. What happens is the humans ingest larvae of the echinococcus, which is a tapeworm found in dogs and sheep and cattle. And usually what we see is a single well-circumscribed nodule or mass, from anywhere from 1 to 15 centimeters. It's usually in the lower lobes, especially the right posterior, likely due to kind of transdiaphragmatic spread of the infection. Unlike the liver, these usually don't calcify. Why do we get the water lily sign, particularly in the lungs? Well, that occurs when air enters the cyst via bronchiopericystic fistula. So then the fluid drains out, and all those daughter membranes kind of float to the bottom. Now we'll end this section with air cysts. They're mimics of cystic lung disease. So here we see some lucencies in the lungs. I got a zoom in picture there. This is a smoker. So this is just emphysema, right? You have a lucency, but there are no walls. There has to be a wall for it to be a cyst, and it conveniently has the central dot sign, which represents the central bronchovascular bundle. Now, for this, does this person have a cystic lung disease? Well, not exactly. They have restrictive pattern on PFTs. This is actually honeycombing. So this patient had UIP or IPF. I know some of you listed that, I think, for the Hermansky-Putlick case, but this is a case with exuberant honeycombing. And what we're seeing is really specific for fibrosis. It's end-stage fibrosis. You're seeing clustered cystic air spaces. typically of similar diameters. They always start by touching the pleural space, and they have relatively well-defined walls. Finally, our last mimic. This patient had recurrent infections. If you could scroll up and down, I'd tell you that these are actually all communicate with the airways. This is cystic bronchiectasis. So in these cases, we see these cyst-like bronchi, air fluid levels are common. This case is lower lung predominant. So the primary thing on your differential will be primary ciliary dyskinesia, or Carter-Gainer syndrome is when that is combined with situs inversus, which this patient obviously does not have, at least. Common variable immunodeficiency can also present with lower lung predominant bronchiectasis. William Campbell syndrome primarily involves the 4th to 6th order bronchi. Recurrent infections and aspirations certainly can be lower lung predominant. Cystic fibrosis tends to be more upper lung predominant. For whatever reason, this case actually was a super rare case of lower lung predominant cystic fibrosis, but for your learning and for all other cases that I've seen, cystic fibrosis is an upper lung predominant disease. All right, now we'll get into our true cystic lung diseases. I've divided this next section into a couple cases. One, we'll start with a neoplastic cause of cystic lung disease. Then we'll do 3 cases that have to do with protein deposition and lymphoproliferative processes. 1 case of a genetic cause of cystic lung disease, and a last case of smoking-related cystic lung disease. So this is case number 1. So this was a 44-year-old who presented to Cornell, or will present to an outside hospital with 2 weeks of progressive dyspnea, non-productive cough. Their COVID was negative. The CT that they got showed a really large left pleural effusion and a left retroperitoneal mass, and they were transferred to us for biopsy. So this is the soft tissue windows on the next slide. I'll show you their CT. Take a look at the right lung where you can see things the best. I'll let it scroll through one more time. Great, so I'll let you think about what you think this is. The answer's on the next slide. Here it comes. This is lymphangioliomyomatosis. And really, this is a slam dunk case. There are diffuse small cysts throughout the lungs and a large left pleural effusion, which is a chylothorax. And we'll go into detail about lymphangioliomyomatosis. So this patient in particular did get a retroperitoneal biopsy that was consistent with a lymphangioma. The pleural fluid was tested and compatible with chylothorax. They underwent glue embolization followed by thoracic duct ligation and talc and doxypleurodesis to help control that effusion. So what is this very long word? Let's break it down. So the lymphatics, lymph, blood vessels, angio, and airways are surrounded by smooth muscle, lyomyo, proliferation. It is essentially an abnormal proliferation of the smooth muscle cells, which are just called LAM cells. And this occurs in the lungs and thoracic and retroperitoneal lymphatics primarily. This actually is a neoplasm. It belongs to the PEComa family of neoplasms because it is the proliferation of these cells, not a malignancy, but just a neoplasm in this PEComa family. So the LAM cell proliferation can surround different structures, and that explains all the findings that you see on CT. So when the LAM cells obliterate and dilate the lymphatics, that's when you end up with chylous effusions, ascites, and lymphangiomas, like you see in these 3 cases. Just in the abdomen, we also can, in LAM patients, even without tuberoscosis, see renal angiomyolipomas. The LAM cells can actually also surround the arteries, leading to hemosiderosis and hemoptysis. This is a really rare case from the literature where the patient ended up having LAM, but actually presented with diffuse alveolar hemorrhage. So you might have noticed in our case that there were some ground glass opacities in the right lung. While not typical, this is rare, that could have represented some hemorrhage from arterial involvement. Of course, the LAM cells also surround the airways, leading to air trapping, cysts, and pneumothoraces. In fact, 81% of patients will have a spontaneous pneumothorax at some point over the course of their disease. So this is a really rare disease, worldwide, over 100 cases per year. It's primarily in women of reproductive age with a mean age of 34. The etiology isn't known. Hormonal factors likely play a role in the pathogenesis and clinical course. For example, menstruation, pregnancy, and OCPs may exacerbate the symptoms. They usually have progressive, it's usually progressive and presenting with chronic dyspnea and cough. So what are you going to look for on CT? So you're going to see round cysts with minimal variation in size. They're usually relatively small, 2 to 5 millimeters. The variation in size can increase as the disease progresses, but usually they're relatively minimal variation. The cysts are going to be diffuse in the craniocaudal plane throughout the lungs. There might be a little bit of sparing of the extreme lung apices, but other than that, it's diffuse throughout the lungs. And typically, except for those rare cases where they have some hemorrhage, the parenchyma surrounding the cyst is going to be normal. Here's a companion case. Again, you see diffuse small cysts throughout both lungs with similar sizes, and the lung apices relatively spared. On gross specimen, you see multiple cysts. On pathology, you're going to see atypical smooth muscle cells, which we call the Lamb cells, that all tend to that stain with a stain called HMB45, and that's diagnostic. So what's the difference between Lamb in someone with just isolated Lamb and someone with tuberous sclerosis and Lamb? So patients with tuberous sclerosis can also get something called multifocal micronodular pneumocyte hyperplasia in the lungs. This, quite honestly, is not something that we're going to diagnose on CT. It looks to us just like little nodules. But if on pathology they diagnose Lamb and see these MMNPHs, then it's always somebody with tuberous sclerosis. That doesn't happen. Those don't form in patients with just Lamb. Chylothorax is less frequent in patients with tuberous sclerosis, but they more often get renal angiomyolipomas. The thought is that both of these entities have the same gene mutations, but it's thought that patients with Lamb only carry them in a small population of cells, whereas patients with tuberous sclerosis have them more diffusely throughout the body. So I'm just going to bring up a couple histologic mimics and things that might get confusing just even by the name sounding familiar, similar to Lamb. So benign metastasizing leiomyomas. This is actually just hematogenous metastases from morphologically benign tumors. Usually it happens after a hysterectomy, like in this case. This was an interesting case because there were a lot of cysts, but that's not typical. There's almost always nodules present though. The typical presentation is nodules, which is something you don't see in Lamb. Similarly, metastatic leiomyosarcoma, on the other hand, not benign, obviously a malignancy, and you are not going to typically see cysts. You're going to see nodules as the metastases. Certainly, like other sarcomas, you can get spontaneous they can cause pneumothoraces, and you can get cavitation of the nodules. This last entity I bring up because I think the name can be confusing. With Lamb, this is called diffuse pulmonary lymphangiomatosis. So no, not lymphangiomyomatosis. So there's not that smooth muscle component. This is actually just widespread proliferation of the lymphatics. It typically is found in children and young adults. It's progressive. Unfortunately, a poor prognosis. There's not much you can do. Unlike Lamb, the process is confined to the normal lymphatic pathways. So you can see here, there's infiltration of the mediastinum, thickening of the pleura and a pleural effusion, and interlobular septal thickening in the lungs. Everywhere the lymphatics run, there is thickening. Unlike Lamb, it doesn't actually infiltrate into the lung parenchyma. All right, moving on to case 2. So this was a 76-year-old. They had MGUS and hypergammaglobulinemia. I'll give you a minute to look at the images. See, lots of people got the last case. Excellent job. So in this case, you can see that there are a lot fewer cysts than the lamb case, right? And they're very variable in size. We have this huge cyst in the right upper lobe and like other size cysts elsewhere. This is lymphocytic interstitial pneumonia, or LIP. So follicular bronchiolitis and LIP are on a continuum of reactive polyclonal lymphoproliferative disorders. Follicular bronchiolitis is just surrounding the airways. So you tend to see central lobular nodules, mosaic attenuation indicating air trapping. And in pathology, it's just a lymphoid follicle adjacent to the airway. So just surrounding the airway. LIP, on the other hand, is diffuse infiltration of the lymphocytes involving the alveolar septa, and which are normally spared in follicular bronchiolitis. Now, what are you going to expect to see in LIP? Usually you see few cysts of variable size. Most are less than 3 centimeters, but they can get pretty big. They're often perivascular. So you can see like there's a vessel running right along the wall of the cyst. There might actually be superimposed ground glass opacities. So another distinction from LAM, in which the ground glass opacities are quite rare. In LIP, it is not so rare. So here are some companion cases from the literature of LIP. Here you can see there's central lobular nodules, there's peribronchovascular thickening, there's ground glass. This one even better, showing that peribronchovascular thickening. And in the last case, more cysts. Now, LIP has a huge list of associations. Probably the first one that comes to mind is Sjogren's for you, which for a good reason, because it is the most common. But just for your edification, keep in mind that the list is actually quite long in things that can be associated with LIP. But in order to make it simple, try to at least remember the most common ones. So autoimmune disorders like Sjogren's, rheumatoid arthritis, and lupus. Dysgammaglobulinemia, usually a hypergammaglobulinemia. Remember, that's what was in our index case. And infections like HIV and EBV. Moving on to case 3. This patient is 53-year-old, and here they have Sjogren's. And they just found all these nodules when being treated for pneumonia. So you can see there are a lot of cysts. But there aren't just cysts, right? There are a lot of nodules, and here I'll show you on the soft tissue windows. What else do they have with them? Really coarse calcification. Give you guys a minute to think about it. Sjogren's, and then in the lungs, cysts and nodules with coarse calcification. All right, this is amyloidosis. So I definitely want you to, keep that in your mind. Cysts and calcified nodules, think of amyloidosis. So there are 2 main forms of pulmonary amyloidosis. You can get nodular parenchymal and diffuse alveolar septal parenchymal. Certainly in the chest, you can get airway involvement, mediastinal involvement, cardiac involvement with a systemic amyloidosis. We're not really going to go into that, except I do want to share this slide just because I think it's, really pertinent for trainees in particular to help with your differentials of airway thickening. We like to divide it by sparing the posterior membrane or being circumferential. The 2 things that spare the posterior membrane with tracheal thickening is TBO, or tracheobronchopathia osteochondroplastica, a benign entity, and relapsing polychondritis. And circumferential thickening of the trachea, you're going to think of amyloidosis and GPA, or granulomatosis polyangiitis. So just to help you with your differential, this is like a key thing that's often asked on our boards. Nodular parenchymal amyloidosis is usually found in asymptomatic adults in their 50s and 60s. And what you're going to see is calcified nodules that are pretty much stable or slowly grow over multiple years. Cysts are actually rare, but when you do see them, it's usually in someone who also has Sjogren's, interestingly. Diffuse alveolar septal amyloidosis, on the other hand, is really difficult by imaging. There's septal thickening, nodularity, consolidations. For all intents and purposes, if I saw this, I would most definitely think of lymphangitic carcinomatosis over amyloidosis. So it really ends up being a biopsy diagnosis, but can have a really extensive appearance like this. So to summarize a little bit, Sjogren's is associated with an AL amyloidosis, and reactive neoplastic lymphoproliferative disorders like LIP and malt lymphoma. Sjogren's patients, when they have amyloidosis, usually have a localized pulmonary amyloidosis, so not the systemic disease. And it usually follows the diagnosis of Sjogren's by 1 to 25 years. So usually the pulmonary amyloidosis in Sjogren's isn't as dramatic as those with systemic amyloidosis. When we see cysts in amyloidosis, like I mentioned, it's usually in the setting of Sjogren's. Now, interestingly, here's a case I had from Colorado where they had their lungs biopsied and actually had both LIP and amyloidosis. So the ground glass opacities you see were probably due to the LIP, the nodules were probably due to amyloidosis, and the cysts could be due to either amyloidosis or LIP, obstructing those small airways. Moving on to case 4. This patient had a history of myeloma, and they presented with recurrent left pneumothorax. I'll let it scroll through a couple times. This is a tough case. We see a lot of cysts throughout both lungs, varying sizes. But then there are all these nodular areas of consolidation. And if you look carefully, I forgot the soft tissue windows, but if you look carefully, you can see that there are some areas of calcification within those soft tissue. If I saw this case, I would probably start with amyloidosis. And I think I'd be on the right track, and you would too, because you thought cysts and calcified nodules or masses. I'm going to think of amyloidosis. And we'd almost be there because this would be light chain deposition disease, which I think of as kind of like a sister disease to amyloidosis. They're both light chain deposition diseases, but in light chain deposition disease, those light chains don't crumble up into amyloid fibrils. So light chain deposition disease affects men more than women. It's usually multisystemic, involving the kidneys, liver, heart, but it can be localized, including localized to the lung. And it has one really important association, and that's lymphoproliferative disorders. 75% of patients with light chain deposition disease are going to have either multiple myeloma or MGUS. So getting your SPEP, UPEP, urine testing, that's going to be really important in these patients. It's sometimes associated with autoimmune conditions, and it's rarely idiopathic. So similar to amyloidosis, light chain deposition disease can be divided into diffuse and nodular types. The diffuse kind, the light chains involve the basement membranes, and it can be multisystemic, and it has a worse prognosis, to the point where some people argue that distinguishing it from diffuse amyloidosis is really not that important, because the prognosis and treatment and management is equally as terrible, and the distinction just isn't key. Nodular light chain deposition disease does have a better prognosis. It's more often localized to the lung. And the distinction between nodular light chain deposition disease and amyloidosis is important, because nodular light chain has a higher incidence of lymphoproliferative diseases and plasma cell dyscrasias. Remember, we said 75% have multiple myeloma and MGUS, and therefore they more often get renal failure compared to those with nodular amyloidosis. What are you going to see typically in light chain deposition disease? Most of them have nodules. So that's going to be in like 89 to 100% have some sort of nodules. They're usually solid or subsolid. They're usually not calcified, unlike amyloidosis. And they can even be FDG avid, which won't help you. In this case that I'm showing here, actually, this woman found these nodules were found incidentally. They ended up getting a PET CT, and everybody was worried about some occult malignancy, but the biopsy showed light chain deposition disease. Most patients have thin-walled pulmonary cysts. Are there any helpful characteristics to these cysts? Well, usually there's vessels in the walls of some cysts, but we also saw that in LIP. Remember, I said that they can be perivascular. But one identifying feature that has been pointed out in light chain is that at least one cyst has a traversing vessel through it. So something to kind of keep an eye out for that might lean you in this direction. Now, I've presented you honestly with a bit of a diagnostic dilemma, and so I'm going to try to clarify it here for you. I said that Sjogren's is associated with amyloidosis, it's associated with LIP, and it's associated with light chain deposition disease. All of these can cause cysts and sometimes nodules. Plus, I told you that Sjogren's is associated with malt lymphoma, which is usually a nodule. So what I tell my residents is, when you're studying for the boards is going to say Sjogren's and show you cysts, and you say LIP. That's the board's question. But in real life, just keep your mind like a little more open and think of these other things. And very importantly, if you see a nodule that's increasing more steadily in these patients, then think of lymphoma, because they do have a relatively high lifetime risk of having lymphoma. All right, moving on to case 5. This is a 48-year-old found to have bilateral renal masses and hamartomas. So I'll let it go again. There's not that many cysts in this person, but look at the shape of the cysts. They're not too round anymore. Kind of funny shaped. So this person had Birt-Hogg-Dubé syndrome. This is rare. It's an autosomal dominant disease. They have a typical skin lesion called fibrofolliculomas. They look like little kind of tan bumps on their face. They also get benign or malignant renal tumors, either renal cell carcinoma or an oncocytoma, with a lifetime risk of about 16%. So they do need a serial screening of their kidneys. And what you're going to see about these cysts is that they tend to be what's called floppy or elliptical in shape, and often paramediastinal. So they don't look round like in all the other diseases that we showed. These patients also, like most cystic lung diseases, can get spontaneous pneumothoraces. Often that's how they're diagnosed. I'm going to show you a series of companion cases, and I want you to pay attention again to the shape of the cysts and the location. So right, they're very floppy and paramediastinal, a lot of them. Again, floppy shaped, elliptical, a lot of them abutting the mediastinum. This one here, look how elongated it is, not round. Even this one along the fissure, they tend to be, hugging the mediastinum. So we actually took a look at this. We took patients with Birt-Hogg-Dubé, LAM, and LIP and tried to see if we could come up with an algorithm to distinguish them all. And what we found was that if the cysts were diffuse, not counting that little perhaps sparing of the lung apices, if the cysts were diffuse, then the patient almost certainly had LAM if they were female. Keep in mind that LAM is a disease in females. It does not occur in men unless they have tuberous sclerosis. So if it was diffuse and it was a woman, then it was LAM. If they had a lower lung predominance, and we found that there were greater than 2 elliptical paramediastinal cysts or a disproportionate amount subjectively of paramediastinal cysts, then it was most often Birt-Hogg-Dubé. So why are the Birt-Hogg-Dubé cysts elliptical, whereas all the other ones are round? The Birt-Hogg-Dubé cysts are thought not to really communicate with the airways. So they tend to be located more laterally in the secondary pulmonary lobule, and therefore the elastic recoil forces of the lung act asymmetrically on the cyst, pulling it open into a lenticular form as opposed to round. Whereas in the other diseases we talked about, there is a small airway communication, and the elastic recoil forces of the lung are therefore symmetric, so it ends up being round, which I think is pretty cool. So Birt-Hogg-Dubé is a genetic disease. Just to point out one other genetic disease that can cause cysts, neurofibromatosis. Interestingly, I'm sure you learned about it in every part of the body, neuro, all the way down to the toes. And so they love to test it, but in the lungs, it can actually cause cystic lung disease as well. So for our final case, we have a 51-year-old smoker, smokes 1 pack per day with dyspnea and exertion and airflow obstruction. So this was in 2012, this was in 2014. I'll give you a little time to think about these images. All right, I see people chiming in already. Excellent. Excellent. So for those that are getting it, we see there's upper lobe prominent bizarre shaped cysts as well as some nodules. And then they sort of coalesce in what is almost difficult to distinguish from just severe emphysema. As many of you guessed, this is Langerhans cell histiocytosis. It has a predictable progression. They have ill-defined central lobular nodules. They then become cavitate and become upper lobe predominant bizarre shaped cysts. That's a buzzword, bizarre shape, because they can have a little polygonal shape to them. It tends to spare the costophrenic angles. And as it progresses in end stage disease, it can be difficult to distinguish from severe emphysema. Here's just another two companion cases. Patient 1 is kind of that typical picture of the bizarre shaped cyst. This, I think, would be, bread and butter, perfect for a board exam. Patient 2, that would be a very difficult case, more likely to see in real life, where you're wondering, why does their emphysema look so strange? And it's just, kind of is burnt out Langerhans cell histiocytosis. So I'm going to end with my approach when I'm looking at a case and, how to think about it and pull all together the different entities that we've seen. So for the first thing to do, obviously, is to determine are true cysts present. So remember, they have to have walls, try to distinguish them from other things like honeycombing and cystic bronchiectasis. So if the cysts are there and they're diffuse and the patient is female, it's almost certainly LAM. If you see a disproportionate amount of elliptical paramediastinal cysts, then think of Birt-Hogg-Dubé. Scroll down to the abdomen and just double check if there's any renal tumors. If you see a vessel traversing the cyst, then you might suggest light chain deposition disease. Keep in mind that all of these are kind of just, for a lot of the cystic lung diseases, you're just trying to move certain entities to the top of your diagnostic differential. So especially for light chain deposition disease can be hard to diagnose prospectively, but you can suggest it, especially when you see these, that feature. Is there an upper lobe predominance and they have a smoking history? Think of Langerhans cell histiocytosis. Double check for that smoking history, look for other signs of emphysema, and look for the little nodules. Is there posterior predominance? Think of tracheobronchial papillomatosis and check the trachea for any tracheal nodules. So are there nodules along with the cysts? If they're big and calcified, think of amyloidosis and of course including metastases. Remember that things like mucinous cancers from the abdomen, osteosarcoma, those can have calcified metastases. If they're big and non-calcified nodules, your differential broadens a little. It can still be amyloidosis. Then you start including light chain deposition disease and of course metastases. Or is it more central lobular nodularity? Then you might think of things like follicular bronchiolitis and LIP, which is an airway-centered process. And finally, are there ground glass opacities? Think of pneumocystis pneumonia if it tends to be central predominant. Look for a history of HIV, usually with a CD4 count less than 200. Are the ground glass opacities lower lobe predominant? Think of DIP. Look for coexistent emphysema and a smoking history that's a pretty long smoking history or a high number of pack years. And of course, LIP can have ground glass opacities associated with the cysts as well. So I'm going to end with that, and I'm happy to open it up to the group, and I'm going to stop share and answer any questions that you guys have. You guys did an amazing job. I saw you nailing a lot of the cases. Awesome. I hope that was helpful, and let me know if you have any additional questions.
Yes, thank you so much for this amazing lecture. And I think everyone enjoyed this lecture today. So if you guys have any questions, can you please type it in the chat box? And I have the first question. So
sure.
I'm going to type it in the chat box. So let's see.
I see. In the case of HPV, if you see a rapidly developing nodule, do you report it as squamous cell or any other differential diagnosis? So that's a really good question. So, that's something that is often taught with tracheobronchial papillomatosis and HPV infection, that they're at risk for squamous cell carcinoma. In reality, it's pretty rare. But I certainly, if one of those nodules is enlarging faster than the others, I would, significantly faster, I would recommend, tissue sampling.
Okay, thank you so much. Any other questions?
Certainly, if you guys think of questions later, Islam has my email and I'd be happy to answer questions anytime. So what's the difference in your imaging in between benign cavitary lesions and malignant cavitary lesions? Is wall thickness a rule? So at least for solitary cysts, wall thickness has been shown to be associated with malignancy. So the thicker the wall, the more likely it is to be malignant, particularly, and that's really more for solitary lesions. That being said, sometimes it can be difficult, for example, in patients that are, if you're dealing with, like, for example, a man with COPD, older age, emphysema, and you have an upper lobe cavitary mass, essentially, on the one hand, sure, it can be adenocarcinoma or squamous cell carcinoma, but those patients are also at risk for typical nontuberculous mycobacterial infection, which can look just the same. So unfortunately, sometimes you're kind of stuck with giving a little bit of a differential and doing tissue sampling as well. In that case of metastatic leiomyoma, can we suggest a diagnosis on the imaging basis? So I think metastatic leiomyoma is a difficult thing to diagnose prospectively. We did suggest it as a part of the differential in that case. I think in that case, with the nodules, you certainly have to think of metastatic disease, but it's key to look in the history and see if they have that history of hysterectomy, because that's going to be in the vast majority of patients. So I hope that answers your question. The name of the paper concerning case 5. Was that is that the Birdhog Dubé paper?
I think so.
Okay, I'll add that to the chat shortly. Does Kaplan syndrome present with cystic lesions? Typically no. So Kaplan syndrome is rheumatoid arthritis with necrobiotic nodules. Sometimes necrobiotic nodules can cavitate, but I don't really think of it as a cystic lung disease as much as like little cavitary nodules, which, I mean, there's a lot of overlap, unfortunately, with, cystic lung diseases and cavitary things. Any other questions? Do you recommend biopsy for cystic lung adenocarcinomas? Absolutely. So, usually the biopsy is targeted on the more nodular. Usually there's at least a thicker part, a more nodular component of the cyst. If it's more, some of those ones are kind of more amorphous, where there's not really a great biopsy target. Sometimes those will just go straight for resection, especially if we can see on the imaging the clear progression for it getting more solid as it becomes more invasive. Awesome. Well, thank you guys so much. I'll find the link to that article. It was in AJR. I'll add it to the chat. And again, I feel free to distribute my email, and I'm happy to answer any other questions.
Okay.
Thank you so much, Dr. Joanna. Thank you.
Thank you.
Thank you.
Have a good day. Okay.
Everyone have a great day or night.
Okay. طب يا جماعة البيبر موجودة في الشات بوكس لو حد عايز يعني. Thank you.
ايه يا اسلام؟
دكتور هشام سامعني؟
احنا جاهزين كده ولا لسه ولا ايه؟
لا لسه.